Bismillah ar-Rahman ar-Rahim. General management or management of bronchiectasis. The main aim of management of non-CF bronchiectasis or non-cystic fibrosis bronchiectasis are treatment of any underlying medical condition, prevention of exacerbation and progression of underlying disease by daily physiotherapy, and the options for airway clearance include active cycle breathing techniques, postural or autogenic drainage, cough augmentation using flutter valves or cough insufflator, or high frequency oscillation or positive pressure devices, exercise programs important to prevent general deconditioning, and the physiotherapist is also vital during admission for exacerbations to help clear tenacious sputum. Nebulized saline or hypertonic saline may improve airway clearance, although there is no randomized controlled data to support its use, its use in non-cystic fibrosis disease. Reduction of bacterial load and the prevention of secondary airway inflammation and damage with antimicrobial chemotherapy is an important goal, and optimize nutrition or optimized nutrition is also essential, and supportive treatment of associated airway obstruction is very important, and refer for pulmonary rehabilitation if breathlessness limits activities of daily living, and refer for surgery in rare cases for localized resection of the affected area, and refer for the lung transplantation if indicated. The antimicrobial chemotherapy in bronchiectasis, this may be intermittent for exacerbations only, for mild disease, or long term for more severe disease. Antibiotics may be oral, nebulized, or intravenously. Regular sputum surveillance will ensure the likely colonizing organism is known. Patients need a higher antibiotic dose and for a longer time period, usually 10 to 14 days, than people without bronchiectasis. Antibiotic treatment choice depends on the severity of the underlying disease, and treatment response is usually assessed by a fall in sputum volume and a change to mucoid from purulent or mucopurulent sputum with an improvement in systemic symptoms, spirometry, and C-reactive protein. And Pseudomonas colonized patients have more frequent exacerbations, worse CT scan appearances, and a faster decline in lung function. Now we will go to exacerbation treatment. An exacerbation is usually clinical diagnosis with an increase in sputum volume and tonicity and with discoloration. It may be associated with chest pain, hemoptysis and wheeze and systemic upset, fevers, lethargy, and anorexia. The CRP is not always elevated. Treatment depends on the potential pathogens and the resident flora, and nebulized bronchodilators and regular physiotherapy as an inpatient or outpatient may also be needed. Exacerbation of mild bronchiectasis In mild bronchiectasis exacerbation, we will treat as follow, giving antibiotics for exacerbations only, tailored to the colonizing organism, and to review the previous sputum microbiology. The sputum samples should be sent for microscopy, culture, and sensitivity prior to starting antibiotics, but empirical treatment can be started while awaiting culture results. In the absence of prior positive microbiology, amoxicillin 500 mg to 1 gram TID or doxycycline 100 mg BID for 10 to 14 days. Use a higher dose oral regimen, amoxicillin 1 gram TIDs for 2 weeks or augmentin 625 mg TIDs, especially if colonized with Haemophilus influenza. A 2-week course of oral ciprofloxacillin at 500 to 700 mg twice daily if Pseudomonas aeruginosa colonized. If early relapse with a return to purulent sputum within 6 to 8 weeks, consider a longer course of oral antibiotics, as for example amoxicillin 500 mg twice daily or doxycycline 100 mg once daily for 6 weeks. If treatment failure, change to appropriate IV antibiotics until clinical improvement. For those requiring long term prophylactic antibiotics, continuation of a stable antibiotic regime is preferable to rotating antibiotics. A new growth of methicillin resistant Staph aureus, MRSA, first isolation or regrowth in the context of intermittently positive cultures should be treated aiming for eradication. Now, treatment of exacerbation of more severe bronchiectasis. Chronic suppressive antibiotics aims to prevent progression of the disease by reducing bacterial load and preventing ongoing inflammation, thereby reducing morbidity and improving quality of life. Antibiotics are usually given for at least 2 days after the sputum has cleared, often for 2 weeks. If oral antibiotics fail, if oral antibiotics fail, IV treatment is required. This may mean inpatient admission or could involve long line insertion, patient education in self-administration of IV antibiotics, and involvement of home care team. Regular planned cyclical IV antibiotics may be required in those with more frequent exacerbations. First, isolate of Pseudomonas aeruginosa. Initial treatment is a 2-week course of oral ciprofloxacillin 500 to 700 mg twice daily. If this fails and the patient still has Pseudomonas on sputum culture, guidelines recommend consideration of IV antibiotics, usually anti-pseudomonal penicillin, minimum 2 weeks, with nebulized colistin or gentamicin or tobramycin for 3 months, and the combination IV antibiotics, anti-pseudomonal penicillin, and aminoglycoside are only needed if there is a lack of clinical response and or resistance to one or more anti-pseudomonal antibodies. Aminoglycoside antibodies drug levels need careful monitoring as the risk of toxicity is high in this patient group, and in case of giving oral ciprofloxacillin, counsel re-photosensitivity and tendinitis risk, and we should stop if ankle pain, and we should avoid in patients with long QT interval or non-vascular aneurysm. Consider long-term therapy with daily nebulized colistin or gentamicin to reduce levels of Pseudomonas in colonized patients with frequent exacerbations. This may need to be in combination with a macrolide antibiotic if exacerbation frequency is high. And challenge test challenge testing is required prior to starting regular nebulized antibiotics to ensure no significant bronchoconstriction. Now we will go to macrolide antibiotics or use of macrolide antibiotics in bronchiectasis. The macrolide antibiotics have both antibacterial and immunomodulatory properties and decrease mucus production, alter inflammatory mediator release, and inhibit Pseudomonas virulence factors and biofilm formation. 5 trials have reported beneficial effects of macrolides in bronchiectasis with reduced exacerbation rates and improved lung function and symptoms. The drugs are well tolerated, though concerns have been raised about antimicrobial resistance with long term use. Prior starting a long term macrolide, counsel risk of hearing loss, caution in those with impaired hearing and poor balance, check liver function at 1 month and then 8 weekly, avoid if creatinine clearance is below 30 ml per minute, avoid concomitant nephrotoxic drugs, and the baseline electrocardiogram ECG to assess QT interval, exclude active NTM infection with at least one sputum sample negative for non-tuberculous mycobacterium, azithromycin 250 to 500 mg 3 times weekly or 500 mg twice weekly are possible regimens. An antibiotic holiday may be recommended, that's to say, over the warmer or summer months. That's all in management of bronchiectasis. Thank you. But before finishing this video, we should point to other important items in management of exacerbation, that we should assess the severity of the exacerbation, that's to say, increase in dyspnea, tachypnea, or use of accessory muscles, or checking if there is new cyanosis or pedal edema or confusion. Exclude alternative diagnosis such as pneumothorax, pulmonary embolism, pulmonary edema, and should do investigations for confirmation of the cause of exacerbation, which include doing chest X-ray, arterial blood gases, ECG, full blood count, urea and electrolytes. And in treatment of exacerbation, as we said before, the first consideration is giving antibiotics according to the condition and sputum culture and the severity of the disease. Now we'll go to use of systemic steroids for all patients with exacerbations. The use of steroids in bronchiectasis will be in form of inhaled steroids for treatment of associated airflow obstruction or presence of wheezes, or if there is another associated condition such as COPD or asthma. The self-management plan, patients need an individual plan for exacerbations, which usually involves having supply of home antibiotics. For an example, there is some programs on the internet to use of antibiotics at home. Treatment of associated airflow obstruction, as we said before, with inhaled steroids and or bronchodilators. If there is an additional disease process causing this, such as bronchiectasis is in the context of asthma or COPD, there is no indication for inhaled steroids in isolated. There is no indication for inhaled steroids in isolated bronchiectasis. This also applies to oral steroids, leukotriene receptor antagonist, and the phosphodiesterase type 4 inhibitors and methylxanthines. So we should not use steroids or phosphodiesterase type 4 inhibitors and methylxanthines and leukotriene receptor antagonist in isolated bronchiectasis. We use all these medicines if there is associated problems such as asthma or COPD. There is no specific treatment for abnormalities of mucociliary function, although beta 2 agonists may enhance airway clearance. Nebulized hypertonic saline 7% may aid sputum clearance, although bronchospasm may limit its use. Acetylcysteine may reduce sputum viscosity. If required, a 6-month trial is recommended. Annual influenza and pneumococcal vaccinations may be required. Osteoporosis prophylaxis, if there is a reason for use of long-term steroids, as we said before in COPD, as for example, associated rhinosinusitis is seen up to 70%, and treatment with nasal steroid, consider antibiotics if infection likely. Nutrition, treat weight loss or low body mass index aggressively as this is associated with a poor prognosis. Immunoglobulin replacement therapy in patients with immunoglobulin deficiency should be considered. Oxygen for those with ventilatory failure. They use the same criteria for long-term oxygen therapy criteria as for COPD. Non-invasive ventilation hypercapnic ventilatory failure due to end-stage disease may need long-term nocturnal non-invasive ventilation. This can also be used as a bridge to transplantation. Last choice of treatment include surgery and lung transplant according to criteria for transplant. That's all and thank you.